All right. Okay. Let's make a start because I know everyone's busy. So thanks very much for making time. I don't think I've met many of you before. So I'm Jake. I'm a peds liver trainee in Birmingham ST7, and I've kind of followed the academic pathway all the way through so far. So basically, what I had planned for tonight is we were just going to go through a whole bundle of questions, and we'll go through kind of like one standard interview type question, like, why do you want to do this? And then we'll do what have we got next? Then kind of a clinical scenario type question, and then we'll go on to a kind of academic-y question, and then some abstract type questions, and then we'll loop back round, and then we'll just do kind of one of each, feedback after we've done one of each type, and then we'll just keep going until we run out of time. I hope that sounds all right. Any questions from anyone before we get going? Great. All right. So at the top of my list, I've got Asad, but I don't think Asad's on the call. So David Lalna. Okay. Okay. So we'll just start at the top of my list. So David, why would you be a good SFP trainee?
Okay, so I think that I've got three main reasons why I'd be a good SFP trainee. The first is that SFP fits really well into my career plan to be an academic clinician in infectious disease. I've previously developed this line of interest by joining two groups that relate to infectious disease, working on both preventable deaths from sepsis as well as the genomic determinants of severe COVID-19. The second reason I would be a good candidate for the SFP is that I've already put a lot of effort into building up my sort of portfolio of research skills. So for instance, I taught myself coding in R to work on both genetic and clinical data, but I already have solid plans in place to develop this to work on coding in Python and in Bash to work on much larger scale data sets. And the protected time of the SFP would be really, really useful for that for me. I think the third reason that I'd be a good candidate for the SFP is that I plan a career that has a real focus on generalist clinical work. So I've applied for an SFP in two degrees that would allow me to spend a year in a DGH, and this fits in nicely with my own personal career plans of being a generalist, probably dual training in infectious disease and general medicine.
Okay. In the interviews, usually they won't do follow-up questions. They might kind of prod you or something. I suppose we could say something like, what might they say? Any particular achievements that you've had that you think will make you a good trainee?
Yeah, so I've got a consistent research output. At the moment, I'm working on 5 manuscripts with my preventable deaths group, and I'm also presenting at an oral presentation at the largest infection conference in the UK, in Edinburgh, in a couple of days.
Great. Okay. Cool. Thanks. We will we'll go through kind of some more questions, then loop back and then do feedback at the end. All right. Cool. I see you. Asad's just joined the call. Are you okay? Yep. Thanks. I've got the message. Asad, are you there? Are you in a position to chat?
Hi. Yeah.
Hi. Super. Okay. So I'm sorry, this is a slightly tricky question, but would you be able to give us an example of a time when you've not communicated as effectively as you could have? So basically give us an example of a time when you've not communicated appropriately. Leaving, can't hear. Okay, fine. move on to someone else. Okay, we've got Elena. Are you able to chat?
What was the question again?
The question was, could you give us an example of a time when you've failed to communicate appropriately, or a time that a communication scenario has not gone very well?
Oh, that's really difficult. I'm not sure. There have been times, but I wouldn't want to say it to an interviewer.
Yeah, okay. Okay, well, okay. How about then, what do you think makes a multidisciplinary team work effectively?
I suppose if everybody has like clear defined roles, know what each other's doing, there's a good dynamic and a lot of teamwork. I suppose that makes a good MDT. Open lines of communication as well, so you can always go to somebody if you need some help.
Okay, can you tell us a bit more about what you mean by that?
So that there's not really a hierarchy as such, so that everybody's kind of open to communicating with each other, and that they formed good relationships so that the team can work in the patient's best interest, like with one common goal.
Yep. And have you seen any examples of a good MDT that you could mention?
Well, like for example, I've just been in like the CF clinic, so they'll have a doctor that'll see a patient, and they've got like a physio and other people. They work quite well together for like one common goal, and they all know what each other's doing and things like that.
Yeah, great. Okay, thanks very much. That is good. All right, we will keep going on and we'll come back. I'll just write that down. Okay, so Asad, are you back with us and able to speak again?
Yeah, sorry about that.
No worries.
Now, did you ask the question about an example of communication that didn't go well? Was that the question?
Yeah, Lena's very kindly chatted about that, okay. So we'll. Right. Is it all right if I give you a different thing?
Yeah, yep.
Okay, so I will try and share my slides. So, okay. I hope you can see that scenario. So I'll give everyone a few minutes to have a read about that worst day ever. Oh, that's not okay. Fine, we'll do that one. Fine. Yeah. I know in most of the interviews you'd get kind of 10 or 15 minutes, and they probably would have more text, but I think this is fine for now. Okay, so whenever you're ready, do you want to just tell us how you would approach this scenario?
Sure. I think that it's important to prioritize the patients based on clinical need or urgency. So it seems as though there's multiple unwell patients, and it says here that the SHO and the consultant are in clinic and there's no registrar. So I would try and see if there is perhaps anybody else that I could sort of utilize to help me with these scenarios, or perhaps other members of the team, maybe such as nurses or ACPs. I think the patient that I would see first would be the patient who's working hard to breathe and wheezing loudly, just because I'm concerned about the airway for this patient. Whilst I've gone to see the patient, I would just inform the nurse on the ward that I've got multiple or more patients to see, and that I'll be with them as soon as possible. And if they could have sort of the OBS and the drug chart and the notes ready for when I do come to see that patient. But just coming back to the patient who's working hard to breathe and wheezing, I would just assess them using an A to E approach, and just make sure that I escalate if required early on.
Is there anything in particular you'd like to know about them? I have got some more information I can tell you.
Oh, right. Well, I mean, the history, if you have a history, that would be quite useful. And generally,
Yeah.
sort of any OBS.
Yeah, absolutely. So the patient who is wheezing is a 91-year-old woman who was originally admitted with a suspected lower respiratory tract infection and is being treated as a potential bacterial cause. Her heart rate is 140, blood pressure is 110/68, respiratory rate is 28, saturations are 92% in air, has normal temperature, and she has already got a cannula.
So, sorry, what are the sats?
92% in air.
Okay. So, I mean, going through the A to E approach, I would just assess her airway, so I'd make sure it's patent. See if she's talking. See if she's able to talk in full sentences, and that there's no sort of airway obstruction.
That's fine.
Moving on to breathing. You mentioned the sats are 92%, so I would definitely put her on some oxygen straight away. So probably aim for maybe saturations between 94 to 98%.
Yeah, fine. Slightly lost you there.
Hello?
Hey, yeah, can hear you again.
Yeah, okay. Sorry, I would say that I'd give her some oxygen through a non-reread mask.
Yep.
I would also obviously got her respiratory rate, which is, I think, was elevated. Can't remember the exact number. I would also listen to her chest just to see if there's any wheezes, any crackles, or is there anything else I can hear on auscultation?
No crackles, but there's wheeze everywhere.
Okay. And I would also do, if I could get a chest X-ray and do an ABG as well.
Fine. Okay. What do you think is going on here?
I think the patient, I think there's a chance that she's septic.
Okay. Why is she wheezing?
I think the wheeze might be as a result of a pre-existing, perhaps if she has some COPD or some other respiratory condition.
Yep, that's one option. Yep. Is there anything else? Okay, no problem. Fine. All right, fine. So we're giving her some oxygen, and we're going to do a blood gas and a chest X-ray. Fine. What else do you want to do on the ward?
I think it would be, I think moving on to sort of see circulation. Could take a capillary refill time. Also,
it's normal. It's fine. Yeah, circulation's fine.
Get us get an ECG. And
yeah, it's normal. It's fine.
Do some bloods as well.
So,
fine. Some bloods.
Yeah. Okay. Anything in particular that'd be important to do?
Yeah. I think a full blood count, using these, and CRP.
Okay, fine. What if I told you that she started to develop stridor as well as wheeze?
That would indicate perhaps she has an upper airway obstruction.
Okay.
So I think in that case, I'll probably attempt to secure the airway. So do head tilt, chin lift, and probably ask for help, or just escalate.
Okay, and who are you going to call? Don't say Ghostbusters, but who else are you going to call?
I would normally escalate to my senior, so either the SHO or the registrar, but if they're not there, then perhaps, since it's an airway issue, the anaesthetist on call.
Okay, yeah, sounds good. Okay, and anything you want to do for the other patients on the ward, just quickly? You've got a couple of minutes left.
Yeah. I would probably go to see. I'd probably go to see the 82-year-old man who's had a fall next. And again, I'd do an A to E assessment for him. And just a green to rule out any sort of any fractures or any limb injuries.
Okay, yeah.
And then I think lastly, I would see the 78-year-old woman who has a temperature of 38.1.
Yeah. Okay. And what fractures in particular are you worried about with the man?
I'm probably worried about like a neck of femur fracture. Or like a distal limb fracture. So.
Okay. And any other major worries about a fall in an elderly patient?
Yeah, I think you have to investigate why they've had the fall, but also the risk of a head injury.
Okay.
So, yeah.
And any critical bits in the history about that patient?
I'd like to explore why he was admitted, what he's being treated for, if he's had a history of falls in the past.
Yeah. Okay. Cool. All right. Great. We'll leave that scenario there. I have made the clinical scenarios quite difficult, so please don't worry that you're finding them difficult. That's the plan. Great. Okay. We will come back to that horrible situation. Next, I have Elena Kakori. You there?
Hello.
Hey, right. Okay. Could you tell us about how your interests fit with the SFP program in this region?
So, firstly, I would say that I'm applying, for example, in Norwich, so I will speak about how my research interests fit with the SFP in Norwich. So essentially, sorry, can you repeat the question again?
Yeah, so this is your kind of academic research station, and we were wondering how your general interests fit with the expertise in Norwich in this region.
Oh, okay, sorry. I was just a bit. I was thinking that I would speak about my region, and okay.
No.
So
pretend I'm a Norwich interviewer.
Yeah. So basically, I am interested in becoming an academic plastic and reconstructive surgeon in the future. And I have already been involved with the plastic surgery department at the Norfolk and Norwich Hospital. Apart from the clinical rotations, which I would like to undertake while I'm in Norwich, if I get accepted, I would like to expand my interest in breast reconstruction surgery and conducting research on that. I've already been involved in ongoing microsurgical research that is done in the department and created contact with the surgeons there. And continuing from my dissertation thesis, which was on the anatomical variations of the deep inferior epigastric perforator flap, I have already discussed with a potential supervisor in Norwich about conducting further research related to that. For example, on the effect of radiotherapy on implant-based, on patients receiving implant-based versus autologous-based breast reconstruction. So I hope that the SFP Norwich will help me gain more experience in conducting research such as systematic reviews, for example, to, let's say, explore my interests further and achieve my ultimate goal, which is becoming an academic surgeon.
Okay, and how feasible do you think this is going to be in the SFP in the time given to you?
So I know that I will have a 4-month block dedicated to research, which I believe that it might not be enough. However, I think that if I, having already started talking to a potential supervisor about what research I would like to conduct, I believe that I will be able to plan and organize early enough to start collecting data and obviously learning the appropriate statistical methods to conduct a systematic review within the time frame that is given to me.
Okay, fine. Okay, great. Okay, thanks. We will keep going. And so let me share this. Oh, there we go. Yep. Okay. So this was one of the abstracts I sent around. Who do we have? We got Sami. I'm sorry if I've pronounced your name incorrectly.
Yeah, that's correct. Yeah.
Hey, have you had a chance to read this abstract?
Yeah, I've had just a quick look at it beforehand.
Okay, cool. Do you want to just refresh your memory of it and have a couple of minutes, and then we'll chat about it briefly?
Yeah, if that's okay. Yeah, thank you.
Yeah, fine. All right. Well, so whenever you're ready, do you want to just have a go at summarizing that abstract for me, please?
Yeah. Yeah, so this abstract essentially looked to compare two types of insulin with each other. So two insulin regimes. So there was a once weekly subcutaneous insulin icodec versus a once daily insulin degulicec with each other, and they were basically comparing the safety and efficacy in type 1 diabetes. And it's quite an important question because I guess like diabetes is a really common condition, and it's quite important to get the get it as safe as possible for patients. So it was a randomized controlled trial, which is the highest on the hierarchy of evidence, but it was open label, so it was no blinding done. And essentially the patients they use adults with type 1 diabetes who had a HbA1c of less than 10%, and I think, yeah, they had 582 participants who were randomized, and yeah, they were randomized according to the two insulin regimes as mentioned, and the outcomes was to look at the HbA1c change from baseline to week 26 of the study. And what they found was that there was no significant change in the HbA1c between the two groups, which was their primary outcome. But I think in the secondary outcomes, they found that there was a higher severe hypoglycemia in the icodec insulin group, and more adverse events in that group as well.
Okay.
Yeah.
Okay, great. And so in this study, I know you don't have the whole paper, but what do you think that the main sources or potential sources of bias are?
Yeah. So considering that it's not a blinded study, I guess there could be areas of bias such as performance bias. So if the investigators had some kind of vested interest in one insulin regime over the other, because I'm not sure about the kind of funding, if there was conflicts of interest, but I guess they could have kind of favored one group more than the other, but the results don't really indicate that, so I'm not too concerned. So that's one possible bias. Also, there could be some kind of selection bias, because I'm not sure exactly where the participants were recruited from, and kind of what kind of if it was a registry or if it was a certain region that the participants were recruited from, which kind of may have affected the results as well.
Okay.
Yeah, I think those are kind of the main source of bias that I can think of.
All right. What do you understand by the aim? They said it tested for non-inferiority. What does that mean?
Yeah, so essentially, I think they were basically trying to evidence whether so one of the groups, if one of the groups was kind of had worse outcomes than the others, they weren't necessarily trying to improve it. They weren't trying to prove that one group was better, but they were just trying to prove that the two groups, one group wasn't significantly worse than the other, and that they were quite similar.
Okay, yeah. And what do you understand by the term rate ratio, or an estimated rate ratio that they've described?
Yeah, just gonna have a quick look at that, if that's okay.
Yeah, I'll highlight it. It's like there.
Okay. See, from this, I would imagine that it would be similar to possibly a kind of risk ratio. So essentially, they were looking at the number of severe hypoglycemia in group A versus group B. So they essentially kind of worked out the number of the probability of severe hypoglycemia in group A, and divided by the of severe hypoglycemia in group B, and came up with the ratio of 1.9, which suggests that it was higher in group A, which was the icodec group, and the confidence interval suggests that it's statistically significant.
Yeah, great. Okay, thanks very much. All right, super stuff, guys. So we've kind of looped through what I would say probably pretty much one of each kind of question. I've tried to make it probably slightly harder than you will get, because if you practice on harder stuff, then you get into it and it's easy, then that's better than practicing on easy stuff, and it turns out to be harder when you get there. So I hope you don't mind, but in the interest of time, I'm going to be relatively direct with feedback. So David, I liked how you had obviously had thought about this before and had a clear plan. I would have liked to be a little bit more wowed. So this is kind of like the question which you went first. So, this is like ideal or opening question. You walk in and you get some kind of question that's like, tell us about yourself, or why you're applying, or why will you be good, or what makes a good trainee, or whatever. It's the same question, and you just want to knock it out the park. Basically, where you want to get off everything good you've ever done in your life, or whatever the top like 3 or 4 things are, you want to get that out straight away. So I suppose you talked a lot about experience, and that's all very relevant, and I liked it. I suppose I just would have liked to and with that, I have spent, I don't know, X many months working on this project, and we have 5 manuscripts in preparation, and I have a poster that is coming out, and kind of a little bit more tangible and specific. I think the only other thing I would say you could consider adding in, if you wanted to, which some interviewers like in the SFP thing, well, actually all the way through, is on the basis that you will have to achieve the clinical competencies in 20 months that other people would in 24 months. When you were talking about, I'm looking forward to spending some time in a DGH, you could say, well, I have performed well in my clinical exam so far in medical school. I have high confidence that I will be able to achieve the competencies in the necessary time, and I'll work as hard as I need to do that. Something like that. I know it's obvious, but yeah.
Cool, thank you.
Yep. Yeah. Any other thoughts on that? Questions? Fine.
Not from me.
Cool. All right. And then, yeah, Lena, I asked you this horrible question initially about failing to communicate appropriately, which is maybe a little bit unfair. I'm sorry, but it was just kind of to highlight what I would call the kind of questions that I hate getting, because for all these sorts of things, I think if you have something specific prepared and you get asked that question, you can deal with it. But if you don't have anything prepared, it is challenging. So for an AFP, SFP interview, they can't necessarily expect you to have a clinical example, but it could be, whatever I was, out with my running group and I, accidentally insulted the coach or something like that. It could be, playing a band and we got into an argument with the organizer of the venue. That can kind of be your communicated poorly thing. As long as you then say, well, the reason it went poorly was because I didn't listen to them, I interrupted them, we didn't de-escalate effectively, I should have taken a step back, asked for a minute to come back to the conversation. I can imagine this sort of thing would happen again in a clinical scenario, something like that. So that's the sort of way I would tend to approach these. I mean, when you get slightly further on, I always would make sure I had a edited clinical scenario to discuss. Some kind of, I got into some dispute with a parent because they wanted to take their child home, and we got into an argument, but then there was a happy ending, and I will use this lesson going forward, that kind of thing. Yeah. Yasir, got your hand up. Go for it.
Yeah, thank you. I was just wondering, do they want you to be honest because you're trying to make yourself sound as good as possible, and then by being brutally honest with that, you could make yourself look quite bad. So I was just wondering, how, those questions are always the toughest to answer, and what are your negative qualities and things like that as well. So I was just wondering, what like a general approach to that kind of question without sort of negatively impacting you?
Yeah, so I think that if they've asked a specific thing like tell us about when you have not communicated as well as you could have, or I mean, these are horrible questions, but like tell us a time when you were not a good team player. I just would try and think of a few things in advance of time which answer the question, because everyone will get mad if you avoid it and then turn it immediately into a positive. You need to address and say some kind of thing that you didn't do quite well enough. As long as you then say, this is what I did wrong, this is what I learned from it, and this is how it applies in a clinical situation, or this is how I could envisage it being applied going forwards. So I would admit some kind of error. You know, I wouldn't say I punched a parent, but, you know, perhaps I reacted, you know, in a hot manner to someone who shouted at me, and I snapped back at them because I realized I was hungry and tired, and you know that led me to understand the kind of better situational awareness and how that can influence my communication, that sort of thing.
Yeah, thank you.
No worries. Cool. So yeah, so then Lena, you talked about the MDT, and I loved all the points you made. Basically, I just wanted you to elaborate on them a little bit more, because I felt like within 15 seconds you had said all the key bits about an MDT. So what I would suggest is, if you can, again, it takes preparation in advance, but you already had the example of the CF clinic. If you were able to turn your answer the other way around and say, you know, a good MDT focuses on putting the patient at the center and all the clinicians working together to achieve optimum outcomes. I recently observed a good example of this in the cystic fibrosis clinic. The members of the MDT were blah, 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 list all your allied health professionals. And then, you know, you could say the things that I observed that worked really well were, you know, a flat hierarchy. And then there was no trouble in the physiotherapist challenging the consultant on their decision about chest physio or something like that. You know, there was obviously a good relationship between all the members of the teams. There was no animosity, and this helps to ensure clear communication. And yeah, so I think if you were able to have just elaborated a little bit more, that would have made that even better. And the only potential one other thing I would say with an MDT is it's worth acknowledging that there has to be a leader of the MDT who is typically the clinician. Doesn't have to be, but typically they're the coordinator and the key kind of decision point.
Thank you.
Does that sound fair?
Yeah, I didn't think I was speaking tonight, to be honest.
Sorry, I'm sorry. You just if anyone wants to tell me to move on, then just say move on. I promise there's no hard feelings either way. Thanks though. Okay, Asad, we talked through this clinical scenario. I'll put it back up again. I'll send everyone everything at the end, by the way, so you please don't worry about having to write anything down. I'll just send you all my questions and all the everything. So maybe it will have evolved since I did it, but in all the AFP interviews I did, it was you go onto a ward and there are 3 emergencies simultaneously and there's no one available. So you're absolutely right. Yes, prioritize and get help. And I think that you could have been a little bit more forceful about I want help, saying, you know, I know that they're in clinic, but I'm going to call my SHO and tell them, you know, I need some help. if you can't come, you can't come, but you need to call them anyway. And then it's about who you escalate to. So whether there's the medical registrar on call, or some hospitals have a medical emergency sort of outreach team. That's quite common now. And then, yeah, as at the point when the person got stridor, then yes, you'd want to escalate to some kind of ICU team. To be honest, it probably would not be that unreasonable to put out a 222 call if they've got stridor and you're having to support an airway. And that would get the anaesthetist with you, because you might get an examiner who would be concerned that you'd be there kind of bleeping the anaesthetic reg on call who's in the middle of doing an induction for a patient on a laparotomy, who isn't going to call you back for 3 minutes. But if you did a 222, they'd come straight away, or someone will come straight away. And don't, yeah. So it's fine to kind of revisit the get help all the way through. So the point with these, in my opinion, I hope this isn't wrong, try and keep it going and tell us what you're thinking in terms of what a potential diagnosis is, and therefore what you're going to do. So I know you were trying to fix the ATE as you go along, but you know, for example, at the point when you get to the chest and there's wheeze on the chest, I suppose that differentials are underlying health condition with exacerbation of wheeze, in which essentially we're only talking about an asthma or COPD. I haven't told you they've got COPD or asthma. You could have asked directly. Or it's their intercurrent illness. You know, perhaps they've got a bilateral viral pneumonia that manifests as wheeze. So this is deterioration of their intercurrent illness, and that would be probably not a bad differential. But the actual diagnosis, which was difficult, was that they had a lower respiratory tract infection. They had been on clarithromycin because they have a penicillin allergy, and then someone had said it wasn't working, so put them on IV coamoxiclav, and then they'd had IV coamoxiclav, and now they were having anaphylaxis. So this was someone to, oxygen, boom, intramuscular adrenaline, and call ICU, because you don't want to be really treating someone with anaphylaxis by yourself. And then the other people, basically it was, absolutely, the 82-year-old man had a neck of femur fracture because they'd fallen from delirium with an intercurrent UTI, and they didn't have a head injury, but they are on warfarin for atrial fibrillation. Oh, sorry, no one's on warfarin anymore, are they? They're on dabigatran for atrial fibrillation. And the other patient, just had a fever with pyrexia of unknown origin, likely lymphoma. But all that, this patient with a temperature of 38 degrees, all their observations were normal. So an alternative strategy, depends how you want to do it, is you could say 3 patients, I don't have that much information, I'd like to have obs for everyone, all of them, and then I'll decide who I'm going to see first. Some people may choose to do that. Yeah, that's what I was going to say. Does that sound fair? Any questions, comments from anyone?
Would you go through, like, as you're going through the ATE, would you fix each issue as it comes up, or would you do it all at the end?
I think you should say you're going to fix it as it comes up, but you don't necessarily kind of have to dwell on everything to the same extent that you would in a like an OSCE, where you're going to be really rigorous and say, I'm going chest for chest expansion and tracheal position and tactile vocal fremitus. But it's a bit of both. But essentially, fix things as they go along, which you did, and but but say when you get to wheeze, you'd be like, why are they wheezing? Okay, well, perhaps they're wheezing because they've got deterioration of the condition they were admitted with. Going to put them onto some oxygen, order a chest X-ray, do an ECG, get some bloods, do a gas, and then you get told they've got stridor. So yeah.
Thank you.
No worries. Okay, cool. And then Elena, I asked you about how your interests fit with the kind of region in the program. I mean, I loved how specific your answer was. That was really clear, and you knew exactly what was going on. You had a plan, what you were going to do. My main comment, two suggestions were, as someone who knows basically nothing about surgery, I got a little bit lost in jargon at times, and I appreciate it. Probably what you said seems really obvious, and probably at some stage I did know what you were talking about, but the panel will be made up of generalists. So you may say, I want to investigate microcirculation in the free flap. Practically, this means I will be doing a case review or a cohort study or a clinical trial or I know then you went on to say systematic review, but it was just to say, bear in mind jargon. And the other thing that you could have said would be to think about what you would go on to do next. So this is what I want to achieve across the 2 years. Specifically in my 4 months, I've thought about doing this kind of thing. And this will help me, which for some people could be decide if I want to do a PhD, or it could be help me get the preliminary data in order to apply for funding for an MD, or whatever. I know you said I want to go on and be an academic surgeon, but I guess just being even more specific than that, that's a how, not a what. You will execute your career by being an academic surgeon, but what you want to do next is get the data, so then you can get an ACF, so you can get funding to do an MD or a PhD. From the perspective of the people recruiting, that's what they're interested in. But overall, I really liked it. Go for it.
Sorry, I just have 2 quick questions. So just for the first one, so I have like an interview for London, and the London SFP sort of comprises of all the different colleges in London. And I'm interested specifically in gastroenterology, and I would have mentioned in that answer like UCL and in the Royal Free, they have the sort of the National Liver and Digestive Health Centre. And I was just wondering, does that sort of snuff the other colleges? Like, would you avoid an answer like that, saying, for example, UCL and this, and that's why I'm interested in London, just because there's also Imperial, King's College, and you don't want to look dismissive?
No, I think that they like people who come with a plan. You can say, I'm interested in this. I know there is particular expertise, and I really hope that I'm able to work with them. The kind of thing I've thought about is doing, this sort of project, and that's where I hope to end up.
Okay, and just wondering, like, I'm from Ireland, so I don't really have any connections over in UK or anything like that to like have a supervisor or anything like that. Like, do you think that's important at this stage to be like, I've already discussed this, because I don't know exactly what project I would do or what's really available for me as a student from like coming here?
So you don't have to name drop is the most clear point. You don't have to say I've spoken to someone, but you need to have an appreciation of what is going on. So, for example, if you, I just know Leeds and liver well because Birmingham, Leeds, and from a paediatrics perspective. So, for example, if I was applying to a Leeds job, it would make no sense for me to go up there and say, I really want to do, you know, CRISPR screens on explanted hepatocytes up in Leeds, because Leeds doesn't have a setup to do primary hepatocyte work and, you know, that kind of study. That just doesn't make any sense. Whereas I could say, you know, I'm interested in doing liver research in Leeds, and I know that there are several members of the team who are doing a variety of clinical studies. I'm quite interested in hepatocellular carcinoma, and I know that the team have published on this using cohort data. I really like to do some kind of epidemiological study and advance my, you know, techniques in coding and public health and that kind of stuff. So, you know, that shows you've clearly thought about why you're applying there, what your interests are, what the kind of skills you would get are. But you don't have to say, I've spoken to, you know, Professor Jones, and this is what we're going to do.
Okay, thank you very much.
No worries. Great. Elena, was that all right? Any other questions?
Oh yeah, thank you. That's good to hear.
Fine, cool. And then we spoke about an abstract. So, Same, yeah, we spoke about this once weekly versus once daily insulin abstract. You know, you obviously got it, and so this really is kind of minutiae here. I'm picking apart, but that's what we're here for. You could have been a little bit faster in the summary. Try and get it done in more like 30 seconds to a minute. Yeah, that was all. I'm being really picky, but you said an RCT is the highest quality of data evidence. And I think that technically a meta-analysis of randomized controlled trials would, some people would say, is a higher level of evidence. I appreciate that that is a meta level of evidence rather than primary evidence, but yeah. I really liked how you picked up on non-blinded. You know, if you really wanted to go, you know, another step further, you could say that, well, obviously you cannot. Well, you could have not blinded everyone. So you could have blinded people by giving the people who had the once weekly, they could have had 7 injections and just injected themselves every day, but only one of them was live. So they could have been blinded, but you could say, well, perhaps the people who knew they were on once weekly felt that they were having this new flashy drug and therefore took greater care over the rest of their diabetes control. So you said selection bias. Now, in a randomized controlled trial, in theory, if randomization has been effective, that should get rid of selection bias, because selection bias is more a problem for case control studies where you have picked your patients. You could have said, well, I haven't seen the full comparison of the, you know, icodec versus degludec patients, and we would need to compare their characteristics to see if randomization has worked. But that is my interpretation of the selection bias thing. Yeah, I liked your summary of non-inferiority, and then being really picky. It's a rate ratio because they are rates in the sense that these are events per unit time, whereas, like you said, we probably were more commonly talk about risk ratios, which would be events in total, like, you know, deaths across the whole cohort. But here there's as a events per patient year. If you then take the rate, the ratio of the rates, it's a rate. ratio. Yeah. Any other questions or thoughts about that abstract? Or please pipe up if you think I've said something silly, by the way, at any point.
Yeah, thanks for the feedback. That was really useful. Would you say there was any other kind of major biases? Because I was a bit like, I wasn't too sure exactly which ones to mention, but besides the one you've already mentioned, I was just wondering if there were any other major ones.
Oh, just so you would want to see why there were 70 people not included. And that data will be in the paper, you hope. We also don't know here, I don't think, how many people completed this study, so how much dropout there was. For example, was there greater dropout in the ICADEC because they had more hypoglycemia? And it's not a bias, but you could always mention, well, the fact taken patients with not necessarily well controlled, but not terrible control type 1 diabetes, the results may not be applicable to those with a higher HbA1c. But yeah, that's what I had done, I think.
Yeah, that makes sense. Thank you so much.
Okay, you're going then. Right. Any more questions before we carry on? Fine. So who have I got next? John Moritz, are they here? Okay. Yasir, are you free to answer a question?
Yeah.
Okay. So this is in your kind of general station, don't know how you would call it. How would your colleagues describe you?
Yeah, so I would say that my colleagues would describe me as a hardworking, motivated, and outgoing individual. So in regards to my work ethic, like an example which comes to mind is during our paediatrics rotation, we were assigned a group project where we had to perform a systematic review and meta-analysis in 8 weeks. And I took charge on that project and was able to successfully coordinate our team in order to complete this by the deadline. And so that's one example of where I would say my colleagues would have seen my work ethic. Also in the same project, I would say that my outgoing nature and sociability also came to light. So I was able to get along with all the team members and successfully coordinate each other in a non-stressful environment. And in regards to motivation, so my colleagues would see that like with my research output, and I've worked with many people in my course as well with me on various research projects that I've taken lead on, and thus I believe that they've seen my motivation and passion for research as a result. Hello?
Foundation program.
Sorry, could you say that again? It cut out for me.
Sorry, why do you want to do the SFP and not just the regular foundation program?
So since I was like at the beginning of my time in medical school, I've always known that I've had a passion for research, and this stems from my my desire to sort of leave a long-lasting impact on the world when I eventually retire, hopefully. And a testament to this would be the fact that I've spent 6 months performing research during my summers, during my undergraduate studies in high output labs. So I've spent 2 months performing genomic sequencing in the setting of rheumatoid arthritis, and also another 2 months on working on IBD. And this has, so the SFP is research for me is a passion more so than just a hobby or trying to get myself credentials to get a scheme. So I believe the SFP perfectly suits me from my career goals, and the ability to juggle clinical time and being able to achieve my clinical competencies, as well as achieving success in academia, is what motivates me to join the SFP. As opposed to a regular foundation program where I didn't have the chance to perform research.
Yeah.
Did that cut out? Sorry, did that cut out? The connection was bad.
Great. No, that's good. I was just giving you a minute. I'll just give myself a moment following up. No, that's good. All right, cool. Thanks very much. Okay, next person. Abe, you still there?
Yeah.
Hey, you're right.
Hi. Yeah, I'm well.
Okay, I've got a question about communication for you. So, what would you do if you didn't agree with your consultant's plan on the ward round?
Sorry, could you say that again? It cut out, I think, for me. I'll try.
Okay, so I was saying, what would you do if you were on a ward round and you didn't agree with your consultant's plan that they'd made for the patient?
Okay. So the first thing I'd want to do is sort of find out a little bit more about what was going on. So I'd ask them why they'd made the decision that they had, and explained sort of why I maybe didn't understand or wasn't sure, or potentially would have done something different, and sort of try to understand a bit about their clinical rationale. If they were maybe less willing to sort of explain, then I could discuss it with a colleague later, an SHO or registrar. Most likely it would sort of be my lack of knowledge as an F1 that was sort of meaning that I was unsure of their plan, but equally it would be possible that perhaps they've overlooked something or weren't up to date, in which case I want to sort of then try and raise this concern with them in a polite way to make sure sort of patients receive the best care possible.
Okay. Are you aware of any strategies for how you could done with them?
Sorry, could you say that again?
I was wondering, are you aware of any strategies that you could use to sort of make yourself heard and listen to, particularly who is in theory more experienced than you?
I'm not sure of any sort of specific names of strategies, but I guess I want to sort of employ general sort of principles and good communication skills. So wanting to sort of make sure that I came at a position that I might be wrong, wanting to sort of clarify exactly what the issue is, trying to come up with sort of a compromise together, and collaborate, sort of maintaining a level tone, not getting angry or combative or anything like that.
Okay, and what would you do? You said you would try and address it in a polite way. What would you do if the consultant didn't, seem to listen to your concerns when you were saying it in that way?
Okay. I mean, in that case, I guess it depends on sort of what the nature of the situation was. If it was something where I was really worried about patient care, then I might want to sort of make a bigger deal at the time, where I would say that I feel uncomfortable with this decision for whatever reason, and maybe we could sort of revisit it later or discuss it with another colleague. I could try and sort of, if there was another colleague on the ward round, see what their opinion was, and if sort of necessary, escalate to another consultant, my educational supervisor, or think about someone at the trust if I need to, could ask for advice from so speak up guardians, etc. That those sort of people. Whereas if it was something smaller, an issue that I had maybe with how they sort of communicated with the patient, then maybe bring it up later with them, sort of to not make a big deal at the time, and then just sort of explain what I saw, why I was worried, and what my feedback might be to try and come up with a compromise in future to help everyone sort of improve.
Okay, thanks. Okay. You got Lily Jones, you there?
Hi.
Hey, are you all right to chat through a clinical one?
Yeah, yeah.
Cool. I will give you a few minutes to read this.
Thank you. I can't see it. I'm not sure if anyone else can.
Oh,
Yeah, I can't see it yet. It's just saying JM.
sorry. Oh, sorry. That's helpful. Sorry about that. What have I done? Is that any better?
It's just a blank screen for me.
Can you see it now?
Anyone?
Ooh, sorry. I'll just show my screen then. There we go. Can you see that now?
Not yet. Sorry. Don't know if
Yeah,
anyone
I can't see either, but I think last time it did this for like 20 seconds.
No, fine. I will copy it and okay, I will put it in the chat then. Bang.
Oh, thank you.
Does that come up?
Yeah, that's good. Thank you.
Okay, fine. Yeah, sorry about that.
Yeah, I can start.
Right. Okay. So, yeah, go for it. Do you want to how you'd approach this this scenario?
Okay, so there's 3 different patients here that are requiring attention, but I'd start by thinking about clinical need and the urgency of the situation. So from what I know so far, I would definitely start with looking at the 55-year-old woman with saturations of 90% on air, as this could be an airway or breathing problem. And the other 2 patients, I'm not sure. Would I be able to have the OBS for the 72-year-old? That's okay.
Absolutely. I will just type them in. That is easiest. This is the 72. Right.
Okay, so the 72-year-old man is also hemodynamically unstable. At this point, I'd be calling for help because you've got 2 unwell patients. I'd be calling my SHO that's in theatre to start with, or to see if they can come and help, and if are they available or not.
Okay. Yep. They say that they're busy at the moment, but you know they have high confidence you'll be able to manage the situation by yourself.
Okay. So at the same time, I would be asking the nurse if she could speak with the relative to explain the situation, that we've got unwell patients on the ward at the moment, but we'll get to her as soon as possible. But I would. Do you have the rest of the? Oh no, that is the 50-year-old. Okay. Okay, I'd go to the 72-year-old man first, whilst also hoping that somebody else comes to the ward. I'd start with airway. So is he able to talk to me?
Yeah, airway's fine.
Okay. I'd move on to breathing. So his SATs are 94%. So I'd like to put him on oxygen, 15 litres, non-rebreather mask. Has he got IV access in already?
Yeah, no, he doesn't have any cannulas.
Okay, so I'd want to put 2 large bore cannulas into the antecubital fossas. I take bloods at the same time while I'm doing that. Full blood count, baseline LFTs, UNEs, and I'd want to send platelets and for cross matching blood as well, because he's bleeding. With his, I'd want to be checking if his SATs have improved with the oxygen, and because he's got a high respiratory rate too.
Yeah, they're fine now. They're normal.
Okay,
Yeah.
so I'd want to win one of the
another
cannulas.
90. Yeah.
Okay, thank you. I'd like to ask one of the nurses to put up a bag of resuscitation fluids to go over for 15 minutes. And while this is happening, I'll be calling my if there's a MET team, like a medical emergency team, I'd be putting that call out, because I'm sure his news score would warrant that at this time.
Yeah. What do you think's going on with him?
So I think he's got a GI bleed, which is making him hemodynamically unstable. So I'd want gastro to come and review him urgently as well.
Okay. Right. And so what have I told you? It's globally back as 52. Is there anyone else you need to call, or anything else you need to do?
So I think this man is going to need to go to theatre and possibly critical care after. So I'd want to get the critical care team involved early to see if he's a candidate for that level of care.
Okay. And all right. Anything else you need to do on the ward?
I need to check on the 55-year-old lady as well. But her does she have because her SATs are now 94%, is that correct?
Yeah, so that's 94.
I'd want to know more about her, like past medical history. Does she have COPD or any condition?
No, she's previously fit and well. She's been admitted for an elective knee replacement, which she's only just come back from theatre from about, half an hour ago or something.
Okay. I'd want to give her some oxygen for her SATs, to improve her SATs, and I'd also do an ABG and chest X-ray as well at the bedside.
Okay, fine. And let's just do this. Set of odds on that woman now. You've given her some oxygen.
Oh, okay. So I'm concerned now. I didn't see the respiratory rate before, which I should have. I'm concerned that she's had too many opioids from theatre, and she might be on like patient-controlled analgesia that's gone wrong. But I'd be thinking about giving naloxone with her respiratory
Great.
rate.
Okay, and how? Yeah. Okay. And do you know how you give naloxone?
I'm not sure. I would definitely be calling my senior.
Okay, good. All right, super, thanks. Good, we will carry on. Who else we got here? Oh no, we can't. I think there's only a few of us here now, so we might as well just carry on looping around. David, do you want to chat through an abstract?
Yeah.
I'm slow again. Let's do this one.
Only so I haven't had a chance to look through the abstract, so I don't know if someone else who has maybe would want to take it as well, unless we've got a little bit of time to look through.
Have a couple of minutes. Increase the pressure. It's fine. Just do it quickly. It'll be fine. It's all good stuff.
Oh, I think I've read this before because it was at this BMJ this week. I don't remember that much about it, but I'm willing to go.
Okay, fine. Well, I mean, whenever you're free, do you want to just try and summarize this abstract for me, please?
Okay, give me a minute. Okay, cool. So this is a very large cohort study that's assessing the efficacy of a live zoster vaccine in a 10-year follow-up period. So the question they're asking is how well does the vaccine work against like different herpes infections? And also, I think, what were the side effects of the vaccine as well? I take that back. I can't see that in the abstract. So just thinking about PICO format, so the population is more than 1.5 million people in Northern California. The intervention is a live herpes zoster vaccine. There's a cohort study, so there's not a placebo. It's just people who received the vaccine versus people who didn't. And the comparison is just people over that same time period who didn't, and the main outcome they measured was herpes zoster cases as well as ophthalmicus, and the whether or not people got that between the two groups.
Okay, and what was the main outcome, main thing they found then?
So the main thing that they found with this study was that vaccine effectiveness initially was 67%, but then waned afterwards to 15% after 10 years. And that's for herpes zoster. And they found other similar effects of waning, though to a lesser extent, for other sort of herpes diseases.
Okay. And what do you think the implement?
Pardon? Sorry, I think you cut
What do you
out.
think the implications are of this study, or the clinically applicable this study?
So I think one important thing to think about, firstly, so if we think about the population, it is it's 50 years and older, which is like a relevant population for the main sort of burden of these herpes infections. It's the main reason that you'd want to use a cohort study would probably be to think about like adverse effects or the very long-term effects of this, rather than like the exact efficacy size, because it's not an RCT. But what this might give us the best information about is when to start redosing people, when to start revaccinating people. So it would seem sensible to say that after 10 years, we know that the vaccine that you're given is likely to work, say, a quarter as well as it initially did. So yes, this could inform guidelines, but it will definitely also inform the information that we give patients when we give them the vaccine.
Yeah, good. Okay. What do you think the main sources or potential sources of bias are studied?
So one important study, sort of source of bias in this study is that it's not randomized. We don't actually have a control group who were given a placebo. Patients were basically selected on their own choice of whether they got the herpes vaccine. So it's entirely conceivable that the group of people who got the herpes vaccine were more health conscious, or they might be more affluent, or there could be plenty of confounders to make them less likely to get these sorts of infections. Another source of bias in this study is the age. So it's just important to remember that it's not going to be valid for people under the age of 50. So people over the age of 50 are likely to have some kind of aged immune system. A third important source of bias is that this was based in an integrated healthcare system in Northern California, which is a really affluent area of the world. And also, if it is a big integrated healthcare system, that's probably more likely to be people who are, have like healthcare insurance in the US. They're likely to have more healthcare exposures than your standard elderly population in the US who suffer from these infections the most.
Fine. Okay. And they talk about using a Cox regression here. What do you understand by Cox regression?
So I think that Cox regression is similar to, say, a Kaplan-Meier plot, where you can, on a graph, plot, say, the incidence of cases over time of two groups. But I think what Cox regression allows you to is it's regression, not correlation. So you can have an equation, you can like mathematically describe the incidence cases over time, but it also allows you to deal with different confounders as well. So we don't have a huge amount of information about this in the abstract, but during their analysis, it's assumed that they would have analysed this taking account of common confounders. So like the ages of the two different populations, for instance.
Okay. Yep. Good. Okay. Thanks. Great. Let's loop back around and then chat through them. So, okay. Before I get going, my thoughts. Does anyone have any questions or other comments? Okay. Yes, yes. So, I like basically the sort of adjectives essentially that you gave to that kind of, how would a colleagues describe you? I just wonder whether if you this in if you've been asked, why are you a good candidate for the SFP program, whether you might have picked slightly different things, because clearly I don't know what your CV is like, but it sounds like there's other stuff on there that didn't necessarily come out. And I suppose the way I tend to approach interviews is that you never know what questions are going to get down the line. It could be that was your only opportunity to tell them that you've done X many months in a lab and that you've done, you got this prize in medical school, or, you're a volunteer and a leader in some sort of organization. In your first point, I'm sorry, I can't remember what it was. You said hardworking. Yeah, that was great. Hardworking, did a meta-analysis, brilliant. Then your next 2 points, just wanted something punchier to go with it again, basically, because you then started to go on and said, when I said why are you applying for the SFP, you then said how much research experience you'd done and things like that. I think fudge that into the first question somehow.
Yeah, how would I sort of put that with like what my colleagues think of me, because like with the research experience?
Many of my friends know that I'm keen on research, and this has been something I've talked about for years and years. I guess they would describe me as an academic focused individual. They get this impression because I've been doing research for several years whilst even at medical school. I did an elective in this, and I did this and this project, and I did this and this project. This is how I see myself going on, and it's why I'm well suited and applying for this program, something like that.
Okay, thank you.
Yeah, I know it's a little bit awkward, but the interviewers know nothing about you, so whatever you don't say, they won't know. Sometimes they'll have your CV, sometimes they won't. It depends. And then just, I know it wasn't the main point, but you said a couple of like negative things about the foundation program, something like I'm not doing it just to get ahead. I mean, you just don't need to say that, basically.
Okay, yeah.
But overall, very good. Yeah, just stuff it with whatever your top achievements are. The thing that threw me in is when I've gone in ready, why are you here? Why are you applying? A question, and then you go straight into some kind of horrible clinical scenario, and then you're sweating and get completely thrown, and then your next question is your why are you here, and forget to say everything. So that's why it is tricky. So if you can think, these are the things I want to make sure I've said at some point in the interview, and then just make sure you get them out, whatever your top 3 achievements, plans, whatever it is. Okay, cool. Yeah. Then Abe, again, I gave you a slightly tricky scenario, but practicing these things are important. They will come up in some interviews, for sure. So I think your approach is completely right about, what to do if you don't agree with the consultant on a ward round. Check for understanding. Is it just that you've misinterpreted something? Is it that they've misinterpreted something? And absolutely, you came back to this key point of sort of patient safety. This is one where you could use that kind of formula for answering things. So seek more information. Did I just misunderstand? Is there a patient safety issue at the hospital? Consultant telling us to prescribe penicillin to a penicillin allergic patient. Make some initiative. So, for example, man, hey, why don't we give them clarithromycin instead? And then you escalate, as in you speak to either the consultant directly or via the registrar, and then bring in other support. That's the SPICE formula. I guess what I was going for was a little bit. You can sometimes be quite practical in these and think, if I actually speak to the consultant, you might, need to kind of like go up to them, poke them to get them to listen, and then you're going to do it at the bedside and kind of undermine them or not. And some people may respond poorly to that. So there's also kind of described process of escalating your concerns. So I can't remember what it's called either, but where we would tend to question which antibiotic are we prescribing, and are you sure we should be prescribing comoxiclav to this patient? The next step up is slightly more direct, being like, doctor, I think that this patient is penicillin allergic, and then up at the top it's, you must stop, you are going to harm this patient. So clearly some of those are more appropriate to be done at the bedside in front of the patient, and as you want to come back and all kind of take the drug chart off their hand, change it and be like, subtly do it so you're not undermining their authority or kind of making them look bad in front of patients, and it could be dealt with it in a difficult way later. So I think it depends on if it's a patient safety issue. Typically, it would need escalated then and there rather than down the line. But there may be a learning event to happen as well.
Cool, thank you. That makes sense.
Any questions on that? Yeah, no worries.
What was the name for the conflict resolution tool that you were going for? Sorry,
I can't remember. I can't rember. Sorry.
That's okay. I thought I didn't know something.
No, I guess I just meant if there was a kind of way to do it. There's a specific to these kinds of things, but I was just talking about like a general process of if you're being like tonight, I may not listen to you type. Yes, go for it.
Sorry, I could have missed it if you mentioned it already. I was just wondering, how would you sort of say, like, because you wouldn't want to correct him in front of the other team members as well if it's on rounds and make him look bad, and not just only the patient but the team. Like, how you'd say, you don't want to say take him to the side, because obviously, like, you're a junior, you can't really take a consultant to the side. But like, how would you sort of say that in a way where it's like without sort of saying it in front of people?
You louder and slightly more direct to be if you start off kind of saying, oh, why do you want to prescribe this drug, then from there you could say, if they hadn't listened to, I was more obvious and being like, are you sure that this is the right drug to be prescribing, you know, given this blood result? And then, you know, you could show them, and that's still quite a polite academic thing to say. Then the other strategy you could say is, if you were struggling to get through, perhaps you could mention it to your registrar or the SHO if they were able to assist in checking what you said is correct and intervening. But in all of these, it's totally fine in the interview to say, I can a difficult situation, and coming to a resolution will not be easy, but patient safety has to come first.
Thank you.
Cool. But otherwise, it was this was real. So yeah, I mean, I certainly liked how you got some of the information out. I think that maybe I didn't hear, but you can even more clear and say, I would like an SBAR handover for these patients, so a little bit of background as well as their observations. Maybe the interviewer won't give them to you, but that, you know, would help. I think that who you pick to see first is kind of fine. You could have argued if you that they prevent, and if you've got the history that they've only just come back from theatre, then you could say, oh, you know, perhaps this actually is opiate toxicity, not naloxone, or, you know, I'm going to go and see them and see if I think that is the case, in which case the treatment is very straightforward. You know, bit of oxygen and pause their patient-controlled analgesia for a little bit whilst I go and see this guy. If the stats drop or the respiratory rate drops below 8, then we'll give them the naloxone, something like that, while I go and see, you know, the man is bleeding. And yeah, you could have, I guess maybe I didn't give you the answer, but you could have been a little bit more, asked for a bit more history on the bloke and the examination, because blood and stool is one of these, you know, vague things where sometimes there'll be a nurse who literally just hands you kind of a poo in a pot that looks you can ask for clarification and say, when I examine him, or what passed blood in his stool. Yeah, David, go for it.
Hey, I'm not sure if it's just me, but your audio is really choppy at the moment. Just let you know.
Sorry. Sorry about that. I blame the Birmingham weather.
Okay, cool.
I will. Don't know what I can do.
It's got a bit better now. So hopefully it stays that way.
Okay, fine. Sorry about that. Okay, sorry. What else was I going to say? Yeah. So the only other things I had for him were I like that you planned a cross match for the Gold Star. You could have said I'm worried about need for the major hemorrhage protocol if he's bled a lot, and the prompt of the low hemoglobin was for that, really. You just said resus fluids, which is fine, but if you could be more specific and say, you know, plasma light, or Hartmann's, I guess, is fallen out of favour, but plasma light's used. But any other form of crystalloid fluid would be appropriate. Yeah, that's fine. Oh, and I liked how you just dealt with the angry relative. Any other thoughts or questions about that clinical scenario?
Just in regards to like before you leave the 72-year-old, would you want, like, could you say until his vitals have improved, or one of like the surgical registrar, like my registrar has come before I go attend to the 55-year-old woman? Like, is that appropriate to say?
Well, in reality, by the time you've put in 2 cannulas and put up 2 bags of fluids, probably someone else will be there, and or if they've got lines in and fluid running through and you've given a gas to go to the lab, then you've got time to nip out and see someone. But you probably would practically go and see someone else if they were still in the same ward. You probably wouldn't, wander off 2 wards down the way until someone had left. But if you're only just over the way, then I think it'll be fine. That just reminds me, Lily, it would have been good to say at the point when you put in a cannula, I'm going to send a venous blood gas, just because you'd get the hemoglobin back straight away.
Mm-hmm.
Yeah.
Thank you.
No worries. Cool. All right, and then David, with this abstract, yeah, it was good. I just would include the kind of, if you wanted to, you could include like the single headline take-home finding in your summary, and if you wanted to, some kind of implication interpretation of it, which you answered really nicely when we talked about it then, saying how it would impact about counselling and revaccination rates. But to an extent, the rest of the summary just comes out from the abstract, whereas that is your interpretation of it. I guess that may not always be possible if it's a very esoteric abstract, but hopefully that won't be the case. Yeah, discussion of bias was good. What else did I have written down? The only other thing I had down was that I think that these things usually are done by coding diagnoses. So healthcare insurers, whenever someone, whatever comes in, they get various codes that will go through the insurers, which is pretty good, but isn't always perfect. Now, why there would necessarily be a propensity for miscoding in the vaccine intervention group compared to the non-vaccine intervention group is unclear. However, you could say that may add an element of variability within the data. And I think that it sounds, at least from the abstract, like follow-up was good, and it should be from these kinds of things where it's done by insurance. But as a more kind of general point of very long-term cohort studies, you can usually always get away with saying that there may be some loss to follow-up, and then it's unclear whether those who were not followed up were different from those who were followed up, or they, were sicker or died or whatever. And yeah, great description of a Cox regression is really good. Yep. Okay. Has anyone got any other questions about anything?
I just want
to
to ask
one quick. Oh, yeah, you go. That's one.
I was just going to ask, like, what sort of statistical methods and like sort of types of analysis do you think we should be comfortable with in order to describe, like, during the interview, and what you think we should know?
The standard stuff. I don't know, like an odds ratio, a hazards ratio, a number needed to treat, a power calculation, a relative risk, obviously what a p-value is, the components that go into a power calculation. I mean, then there's the kind of more standard tests, obviously, like a t-test and a Kruskal-Wallis test and all that stuff, Kaplan-Meier curve, a Cox regression. I mean, you don't have to know them in great detail. To be honest, the way I used to just, and still do, prepare for these is I just go into PubMed and pick a few big journals, or I'll search randomized controlled trial and I will read through 10 abstracts. And if I don't understand anything, just Google it. And then I'll go cohort study, read 10 abstracts and Google it. Whatever I don't understand, case control study, 10 abstracts, Google it. And then you can't be expected to know everything. But if you can read 30 abstracts and generally understand what's going on, you should be all right.
Okay, thank you.
No worries.
So I missed what you said about something like miscoding. Were you talking about some kind of bias of the study?
Yeah, so in quite a few studies, they will rely on ICD coding, the International Classification of Diseases, for basically knowing what outcomes people have had. So, you know, this was a whatever 1.5 million people. There wasn't someone calling them up and saying, "Did you get herpes zoster?" It will be that when those individuals went to their doctor or their hospital, then they billed the insurance company and said, you know, whoever, Jack Mann has got ICD code C3.4A. And that's the kind of coded diagnosis that means whatever it does. And so in theory, that should be accurate. And it probably is more accurately done in the US than it is in the UK, where coding is used, but it's not used probably quite so meticulously. But it's just a kind of low-hanging fruit of critical appraisal. You can just say, perhaps the coding wasn't as accurate as it could have been. And for certain things that codes don't exist. So it's getting into my minutiae now, but it may be that they have to create a kind of composite code in order to figure out what it is. But yeah, just say that the coding might not be perfect.
Okay, that makes sense. And one just final quick question. You know, would you say like things like for when you ask for, does the study have any biases? Would you say stuff like it wasn't randomized and the population might not be representative, or does that not really come under bias? Because I was a bit confused.
Yeah, so I mean, I think you can say that, particularly if you don't have anything else to say, you can say that. You clearly wouldn't. I mean, I think it's worth acknowledging that this study is a different kind of study. You know, you wouldn't do a randomized study of 1.5 million people followed up for 10 years. That just is not possible. So it's a different kind of evidence. But sort of with it, it's the fact that it's non-randomized, which means that there may be inherent differences between those who did have vaccines and those who didn't have vaccines, and that's more likely to be confounding factors. So, you know, as David had mentioned, it could be affluence, it could be other health conditions that they do or don't have, and have other health beliefs that impact on their behaviors, or, you know, likelihood to seek medical intervention. But I wouldn't just say it's not a randomized controlled trial. You need to follow that up a little bit more to make that answer a bit more accurate.
Yeah, thank you.
Okay. So I will try and share this if I can. Are you seeing this? It might be a bit slow to come through, but it will.
Not yet, but we'll let
Okay,
you know.
give it a minute. Give it a minute, it will. So, I guess, did anyone have any particular kinds of questions they would like to either have a go at answering or to talk through again, or want me to chat through a couple? If not, I'm pulling up my kind of whole long list of questions, and you can just have a look and shout if there's one. Asad, go for it.
I'm not sure if this was addressed earlier. I think it might have been, but if during the interview, if they were to ask you about sort of how you're going to spend your 4 months, and like say if you have like an idea of like your interest areas, but you don't have like a concrete, I guess, like proposal, like one, what would you suggest, and sort of how would you go about answering that question?
I would suggest coming up with an idea now. It doesn't have to be a real thing. It just has to be something. So, for example, I don't know if you can see this now, but if you can see this question, if funding were no problem, what project would you do? No one's going to expect you to know, like, oh, I'm going to get this specific cell line and I'm going to CRISPR in this variant and then I'm going to study it using these assays. But have a general feel for kind of, I'm interested in this disease process. I'm interested in, let's say, I don't know, tuberculosis. And I'm aware that research is done in this unit on tuberculosis. I know that the kind of models they use are, you know, I don't know what you use for modeling tuberculosis. Some kind of rodent, I expect. You know, they use a rat model for tuberculosis, and I would like to gain experience in doing that in my 4-month block. And that is probably about the level of detail that you need. And that is the kind of core of your answer. And then what you would want to do is frame it within the context of, I have been interested in respiratory or infectious disease or whatever it is for several years. I think I want to be a respiratory physician long term, and I want to be a clinical academic. I want to gain experience and understand if I want to do in vivo work long term, and therefore that is the project that I would ideally like to do. But I appreciate that I'm not at the forefront of the field, and I need to get feedback from various supervisors to help me delineate an exact project. That's the sort of thing I'd say.
Thank you.
No worries. Abe, go for it.
I was going to ask, with the clinical prioritization, how would you prioritize someone who had a potentially unstable C-spine, so they'd hit their head on the ward and had pain in their neck or something? Would that take precedence over almost anything else? Or if they were otherwise stable, you would just tell the nurses to immobilize them and then you'd come and see them after the more acute situations?
Good question. I think that, I mean, it's unhelpful for me to say it's unlikely you'll get asked that, but I think it is unlikely you'll get asked that, because usually head injuries happen with elderly or confused individuals who are probably not going to tolerate blocks and straps or any form of even manual inline immobilization. I think that you probably would be totally fine to say, I'm going to get a set of obs on everyone, and I'd like a S-bar handover just so I understand a bit more about the situation. And, I think that you could say, I appreciate that there is a risk of a C-spine injury here. However, I'm going to go and see Mr. Blobby because his saturation's at 82%. I will come back and assess for a head injury, considering C-spine shortly, but this is likely a low impact trauma because in general, people haven't, like, if there was, I don't know, if they've fallen down 2 flights of stairs, then perhaps you would, but usually they've fallen out of bed or from standing, and you're relatively unlikely to have a, you know, what is it called, a spondylolisthesis or whatever it's called.
Cool. That makes sense. Thank you.
Yeah. Any other questions jumped out to anyone they want to talk through?
Yeah, like with that, why do you want to do the SFP question? I sort of struggle a bit to get the balance between like actual reasons that you want to do something versus like flexing all the stuff you've done already, if that makes sense.
Yes. So I guess it's a combination of, you know, without getting too philosophical, kind of both what you want to do now and what you want to do long term, and stringing it all together into a story. And so, you know, for example, you know, thinking about when I applied, I could have said, I've always been interested in research and I want research to be a major part of my career long term. And I want it to be both a clinician and a scientist. So that is why I want to do it, because it gives me dedicated time to do research. You know, I've already had experience through my BSc and being involved in whatever 2 other papers in the meantime. Specifically during the AFP or SFP, I want to see if I want to do basic science research. I had a little bit of a taste to do my BSc, but thinking forwards to doing a PhD long term, I want to determine now whether I want that to be a more clinically focused MD or a wet lab science project. So that is what I ideally would like to do now. And, you know, that will develop on my previous skills or something like that. Something like, yeah. It's a stepping stone to something else. And just a personal feeling about this is I don't like it when people say the reason I'm doing this is because I want to be a clinical academic. A clinical academic is what you are in order to be able to do something. So I think it sounds nice if you can say, I'm interested in this, I want to make a contribution, and the way I can achieve this is by having time to do clinical work, research, and yeah. The other thing I realized we haven't talked about at all, and I'm sorry, it's probably my complete bias in this, we haven't talked about teaching, and I realized I hadn't put anything in this about that. You could, I'm sure it's one of these questions in here somewhere. It's probably just worth preparing something like this. How would you develop a teaching program for FY1 trainees? How do you know you're a good teacher? You know, what's the difference between audit and research? Those kind of standard questions, but how do you assess teaching? What's your favorite style of teaching? That just have in the back of your mind, have prepared a couple of those as well. The one that I find catches me out is if you could give teaching on any one topic, what would it be? So again, another thing that if you prepared it, easy. If you haven't prepared it, it becomes a miserable question. Cool. So I will just send you all the link for this soon. Share it with whoever you want. I don't mind. Yeah, feel free to ping me questions, whatever else. And not really sure how I'll share this recorded thing with other people, but I will do my best. Yeah, good luck whenever your interviews come around.
Thank you so much. That was really, really helpful.
Thank you.
Thanks.
Thank you.
No,
Thank you.
no
Thanks so much for your
problem.
time.
Cool. No worries. Right, catch you later, guys. Have a good evening. See ya.